This conference will now be recorded.
Okay, so all of you, welcome to class. So in today's class, we'll be doing this new cesarean guideline that has recently come in this March 2021. Apart from this related guideline VBAC, though it's a old came early. Apart from this, a few questions. Okay, so now what the NICE says, new NICE, that the 25 to 30% of the women will have cesarean section. So what I would want to tell you that previously this percentage, how much percentage of cesarean birth will be there. So previously it was 25, okay, but now the number has increased. It has become 25 to 30%. So in your exam, if the question comes about the number of women having cesarean birth, so this will be the answer now. So according to new guideline, answer has changed. Okay. Now, according to guideline, what are the factor that mean that women may need cesarean section? So it is increase in maternal age and BMI. So these days, you already know that there is a trend of in having late pregnancy, and also like obesity is increasing. So these are the maternal factor that is causing increase in cesarean section. And what could be the emergency cesarean section factors? That is a slow in the progress of labor, or if any concern about the fetal's condition. Okay, so line number 1 about the number of increase in cesarean section 25 to 30%, and why there is increase in cesarean section because of the increase in maternal age and also BMI. So you may get question from this. Now, like where to do cesarean section, where not to do, according to the guideline, what are the updates are there? I'll keep on speaking. So for the breech, we already know from the breech and ECV guideline that after 36 weeks, we need to offer external cephalic version. And what are the indications for that? We already know. And what are the contraindication? That means it should not be done. If the patient is in established labor, you can't do it. Fetal compromise, you can't do it. Rupture of membrane, vaginal bleed, you can't do it. If cesarean, if any other medical condition like severe hypertension, these are the conditions where like external cephalic version will not be done. So you will get question from here also. It is similar to ECV guideline also. So like where the ECV is should not be done, or it is unadvisable. Apart from this, what they are saying, like if the patient is being taken for cesarean section and the breech is the indication, so what they want that the ultrasound scan to check the position of baby, whether it is in a breech, it should be done as late as possible before cesarean section. So this has been new update in this guideline, that as late as possible before you come do cesarean section for a breech is an indication, ultrasound scan should be done. So you will get some scenario from there, and answer will be this. Placenta previa, it is, we already know that in the placenta previa, minor, major, covering os, it is an indication for cesarean section. Okay, there is no change or no doubt about it. Now, what they say about morbidly adherent placenta. So, if the patient has previous one cesarean section, okay, then in the next pregnancy, color flow Doppler ultrasound should be done at 32 to 34 weeks of pregnancy, and this is a first diagnostic test. And don't get confused with the placenta previa guideline, because in the placenta previa guideline they are doing TVS at 32 weeks of pregnancy, and they are doing to check whether the placenta is still low lying or it has or migration had happened. So read your question well. Placenta previa guidelines say only about the position of placenta, but this says about they are checking about the morbidly adherent placenta in the patient if she has previous cesarean section. Okay, so in this situation, if the previous cesarean section is there, so for your for first line investigation for diagnosis for morbidly adherent placenta will be color flow Doppler scan at 24 to 32 to 34 weeks of pregnancy. You will get question from this slide. Okay. Now, second line, if your color Doppler shows yes, it is morbidly adherent placenta, then what will be the next level? Next level will be going for MRI, and MRI usually they want for posterior placenta if the position is posterior. Why? Because if the position is anterior, even the your TVS scan or any scan will be able to identify the position of placenta very well. But if it is posterior, then it ultrasound there is some limitation because of the position. Therefore, in the posterior placenta adherent placenta, they are considering MRI scan. Okay. Apart from this MRI scan, what the guidelines in, we also know it is done in the pregnancy, but the lack of evidence about the safety data is there, not there. Okay. Now, what they say, this we already know from our placenta Previa guideline, that if the cesarean is being done for morbidly adherent placenta, so what are the prerequisites? It has to be done by a consultant obstetrician. Consultant anesthetist should be there in the operating theater. There should be pediatrics registrar consultant or equivalent should be present. Hematology registrar consultant or equivalent. Okay. Apart from this, there should be critical care bed available. There should be sufficient cross-match blood and blood prop readily available. You may get questions. So this is previous guideline. It was a care bundle. So these are the some components of the care bundle only. Okay, so this you have to know because you may get some SBA from there also, though you know already. It is just a repeat. Now, few things about infectious update, what the guideline says. So if the patient has hepatitis B, we already know that it is not an indication for cesarean section. But why we are worried? We are worried about mother to baby transmission. So what we will do? So baby will be protected with active and passive immunization. So when the baby will be born, so immunoglobulin and vaccination, that they are given when the baby is born. Okay, so this way the protection for baby will be done. Now coming to hepatitis C, so what they say, that if the patient is infected with hepatitis C, so there is no cesarean section. Only for hepatitis C there is no cesarean section. But if she is co-infected with hepatitis C and HIV, then they are saying planned cesarean section to reduce mother to baby transmission of hepatitis C. Now you guys will have confusion, or because in the BHIVA guideline, BHIVA is also this is the update in 2020. So what they say in BHIVA guideline, if the obstetric complication is not there, so vaginal birth can be done in the patient who receives CART for HIV irrespective of HCV viral load. So BHIVA recommend if the patient has HIV and there is no obstetric complication, vaginal delivery can be done. So this is BHIVA. But the NICE guideline for cesarean section says if co-infection is there, then hepatitis C and HIV, then they say that a cesarean section should be offered. So yeah, there is now it has become a controversy, but nobody can give answer to this controversy. If the question come, what will be the answer? But in my opinion, like the guideline that has come latest, so should be the should be taken as an evidence to give answer. So if you can, NICE should get an upper hand over BHIVA. So if the question comes, then you can answer this way, that if the both infection are there, hepatitis C and HIV, so a cesarean section can be offered. Okay, but there is a controversy between NICE and BHIVA. Now coming to so this is again a new thing in this guideline. Now coming to hepatitis herpes simplex virus, that we know from our herpes guideline, that if primary herpes infection is there in third trimester, cesarean section, it has to be planned cesarean section. Why? To decrease the risk of neonatal HSV. And in case of recurrent infection, there is no requirement for any planned section. Okay, this all things are same as from the previous guideline. This is about BIVA that I have already explained you. Now, few things, like if these days the cesarean section rates are increasing on the maternal request also. Okay, so if a patient is coming, this is important for the part 3 people. If the patient is coming, she wants to go for cesarean section, then first of all, we need to find out what the reason why she wants it, requesting for cesarean section. After that, all the risks and benefits should be explained. After that, if she's not listening, then she should be offered further visit to the senior midwife or obstetrician. On the other side, like if you get a scenario, like if the patient is requesting cesarean birth because she has tocophobia, severe anxiety about childbirth, or because of the previous traumatic event, if this kind of history is there in your question, in that particular situation, answer will be offer offer referral to a health professional. Those have expertise in providing perinatal mental health to support to help her anxiety. Okay, so now there are two things you have to understand. If patient has got no history, only she is requesting cesarean section, in that situation she should be put in contact with a senior midwife for explanation or counseling or obstetrician. Okay, but if she has got any history of anxiety, tocophobia, in that particular situation for the counseling, she should be referred to the perinatal mental health team. Okay, so these two part you have to understand, because you will get this is the question, is a common question in part 2 and part 3 both. Now you will get question from this also. So factor that reduces the likelihood of cesarean section, you have to remember it. Continuous support during labor, all of you already know. Partogram with 4-hour action line, because if the partogram is drawn during the labor, then it is very clear that if the patient only seeing partogram will be able to know whether she is going towards prolonged labor or any situation, so the decision can be taken. Apart from this, consultant obstetrician decision in making consultant decision in making like planning for cesarean section. So these are the three factors that would like to reduce the likelihood of cesarean section. Even in the part 3, this question has already come. So how to reduce the cesarean section? Okay, so these 3 lines could be very important for part 3 people also. And for part 2, you know, this comes as a question, you have to remember this. Apart from this, part 2 people also has to remember what doesn't influence the likelihood of cesarean section. So you will get question from here: walking in labor, non-supine position during second stage of labor, immersion in water during labor, epidural analgesia during labor, and use of respiratory leaves. So this part you have to know, because people make confusion here. Epidural analgesia in labor, where if you don't read a question well, so you will mark this. Okay, but actually this has got no influence. Epidural analgesia has no influence on increase in likelihood of cesarean section. Okay, so this you have to remember for part 2 people. And this is uncertainty, just listen to it one time. Like complementary therapy, acupuncture, aroma, hypnosis, herbal product, nutrition supplement, homeopathic, Chinese medication has got no influence. Okay, now coming to what they say about eating during cesarean section. So okay, usually low residue diet should result in the larger gastric volume, and we don't want large amount of gastric volume because the risk of aspiration will be there. So what they say, isotonic drink should be given during labor. There are 2 benefits for it, for isotonic drinks. They will prevent ketosis. Okay, starvation will not be there. Apart from this, there should not be increase in the gastric volume. So if the gastric volumes is not increased, so chances of aspiration will be decreased. Okay, now this is also very important. You guys will get question from this part. Now, a cesarean section should not be done before 39 weeks. That we already know because of the increase in the respiratory morbidity. Now, classification of cesarean section has been done into the categories. What will be the category 1? Category 1 will be the indication for cesarean section where immediate threat to life is there for mother and or the fetus. So a time from decision to delivery interval should be 30 minutes. So these are kind of a crash cesarean, and they should be done within 30 minutes of decision. Okay. Now category 2, where there is life is not at risk, but yes, maternal or fetal compromise is there. So category 2 cesarean section should be done within 75 minutes of a decision made. Category 3 cesarean section, when there is no maternal or fetal compromise, but yes, early like birth has to be there. So there is no time limit for it. Category 4 or elective cesarean section, it is suitable time to patient and to the healthcare provider. Okay. So you already know this is just in revision. So these categories are important to know. Now, what will be the indication for category? Some few examples. Okay. Category 1. So category 1, if the cord prolapse, if the uterine rupture, if the pH is less than 7.2, APH with the evidence of maternal or fetal compromise, pathological CTG, where FBS or fetal blood sampling cannot be done. So for example, prolonged bradycardia. So these are the indication that will call for category 1 cesarean section. So if you like, it is very clear also, but if you could remember it, so your answering of question will become very easy, because sometimes they will give you scenario and you have to just find out what is the category of cesarean section you have to put. Okay. Then category 2, it will be, for examples will be failed instrumental delivery, but there is no fetal and maternal clay compromise is there. Direct maternal fetal compromise is not there. Apart from this, APH, but compromise is not there. Okay, these are the few example. Category 3, for example, malpresentation, no evidence of maternal or fetal compromise, or like if there is a biophysical score is low, but the CTG is fine. So in this condition, cesarean has been decided, but there is no time limit. Category 4 will be or elective procedures. Okay, so this list will be important for both part 2 and part 3 people. Part 2 people, for direct question comes. For part 3 people, this helps in prioritization of your labor ward station. Okay, because there also you have to speak about what you category you would like this patient to send. Now this is again like preoperative testing. The full blood count, antibody screening, blood group with group and safe. So now this part has been added. Antibody screening has been added new in this guideline. Previously, it was not there in preoperative testing for cesarean section. Okay, so this part you have to just now the question will change, and if you don't read new guideline update, so you will make it wrong. So preoperative testing will be full blood count, antibody screening, and the blood group and safe. Okay. These are the routine thing and should not be done as a routine. Cross match, clotting screen, and USG for localization of placenta. This was there in last guideline also. Apart from this, there should be indwelling catheter if spinal or regional anesthesia is used. Why? Because to prevent over distension of bladder. Because of the regional anesthesia. So if the catheter is not put, so it will be the reason for post-op bladder atony or bladder problem. So to avoid over distension, they want that catheter should be put. Now few updates about the anesthesia that we already know. This is few things only are new added here. Like regional anesthesia is preferred. That we already know. The cesarean section is usually done in regional anesthesia, including if the patient is placenta previa also, then also regional anesthesia is preferred. We want patient position should be left lateral tilt with the 15 degrees. Why? The reason we already know, because to decrease or reduce the chance for maternal hypotension. Now, if they are when the spinal anesthesia is used, so we are worried for what? We are worried for hypotension. So to avoid that hypotension, what they have recommended to use prophylactic intravenous infusion of phenylephrine. Okay, so that can be started immediately after spinal, and rate of infusion should be such that maternal blood pressure should be kept 90% or more above the baseline value. So this line has been added new in this guideline. This was not there previously. So if you will get any question, you will get it from here. So rate of infusion should be adjusted. So the maternal blood pressure is more 90% or more of baseline value, and it should not decrease less than 80% of the baseline value. So part 2 people, if they may get question from here. Okay. Apart from this, with the phenylephrine, consideration for intravenous ephedrine bolus can also be done to prevent hypotension. Another new thing, like previously we used to say crystallized preloading. That means we are used to give crystalloid to load women before cesarean, before she goes for cesarean section. Now in this guideline they are saying crystalloid co-loading. Okay, so that means these are the vasopressors. Along with it, co-loading should be done. So this apart from this, like to what should be done to prevent risk of aspiration in the cesarean section. Otherwise we already know that Mendelssohn syndrome occurs. So there are 3 components. This is from the old guide, this is there in the previous guideline also. So pre-oxygenation, cricoid pressure, rapid sequence induction. If these are the 3 things that should be done in the GA, if the cesarean section is done in GA, to reduce the risk of aspiration. Okay, so like these are the, you may get question from there. So what can be done to reduce the risk of aspiration when the patient is going for cesarean section in the general anesthesia? Okay, so only this yellow line is the update, and this crystal co-loading is an update from the new guideline. Now this is also update. This was not there in previous guideline. So whatever the fluid, IV fluid or blood products that are being used during cesarean section, so usually they should be warmed up to 37 degrees Celsius using a fluid warming device. Okay, it was not there in previous guideline. Apart from this, we usually the irrigation fluids are used. So what they want, what temperature for irrigation fluids, it is little higher. It is 38 to 40 degrees Celsius in thermostatic controlled cabinet. So irrigation fluid temperature is 38 to 40. All this temperature range is important for part 2. Now, sometimes the patient is having like a hypothermia during, or they are shivering, they are feeling cold. So what should be considered? Forced air warming. Forced air warming, so certain warming air devices are there, so they can be used. So this is an update. This was not there in the previous guideline. Okay, till now any one of you have got any question, or should I keep on going ahead? Any question? Any question? Okay, no question. Okay, this is also new in this guideline. So method to reduce infectious morbidity. So for the skin preparation, like what they want, first line should be alcohol based chlorhexidine. Now if it is not available in the hospital, then they should use alcohol based iodine. Okay, so in skin it is chlorhexidine followed by or alcohol based iodine, but it is reverse in vaginal preparation. In vaginal preparation, what they are saying, aqueous iodine vaginal preparation before cesarean section with a woman where a rupture of membrane is there to decrease endometritis. So it is like vaginal preparation or vaginal cleaning with the aqueous iodine. But if it is not available in the hospital, or if it is contraindicated, consideration for aqueous chlorhexidine vaginal preparation can be done. Okay, so 2 things you have to remember. For skin, they are using alcohol based preparation. Even we use same in our hospitals. So chlorhexidine is first, that will be for, if it is not there, then consideration for like alcohol based iodine. The reverse is, it is in the vaginal preparation. For vaginal preparation, they are using aqueous preparations. First will be iodine. If iodine is not there, then the second line will be chlorhexidine. Okay, so this was not there in previous guidelines, so you may get question from here. Apart from this, now what they say about the abdominal wall incision, that we already know, it is a Joel Cohill incision. So it is a straight skin line incision 3 centimeter above symphysis pubis, and subsequent layer has to be opened bluntly. Okay, and if extension is required, then they want to use scissor, not knife. Why it is so? Because it will help, there will be shorter operative time, and there will be decrease in the post-operative febrile morbidity. So this is the Joel Cohen incision that we already know. Now, instrument for skin or instrument for like a knife for deeper tissues. So it has to be like, they don't want knife to be changed. It should be same knife, because change of the knife is not associated with any decrease in the wound infection. Okay, now if you now coming to the intra-abdominal, uterus is there, then you have to see what they recommend. If the lower uterine segment is well formed, and after giving incision, you have to extend it. So what they say, use the blunt method of extension rather than sharp to increase the uterine incision. Why? Because there will be decreased blood loss, decreased chances of PPH, that is requiring transfusion during cesarean section. Okay, so if the lower segment is well formed, they want blunt method for the extension. Now coming to the forceps, only use of forceps, it is not routine. It has to be done if there is difficulty in taking out the head. Okay, now coming to uterotonics, we already know this and this is a very common question that keeps on coming. So if the cesarean section is done, so what we used for active management third stage of labor? So it is oxytocin 5 international unit by slow intravenous injection. Okay, that will increase the increase the contraction of uterus, and that will decrease the blood loss. Okay, apart from what they say about the method of placenta removal, it should be CCT, that is a control cord traction. So like this is what the guideline recommends. Now coming to uterus repair, they recommend that the uterus repair has to be keeping uterus intraperitoneal. Okay, they don't want to bring uterus outside, because what the research have shown, if the uterus is brought outside, then it is associated with more pain and doesn't improve operative outcome. No, so there is no benefit of it. So they recommend to perform intraperitoneal repair. Now this is again new in this guideline. Closure, what they say, so it can, if the single closure is done, or if the double layer uterine closure is done, it depends, like whatever the circumstances are there. According to this guideline, if the single layer closure is done, it will not increase post-operative bleeding or uterine rupture in subsequent pregnancy. This line, it was not there in previous guideline. So it is important to know. So what they say, that single layer closure of uterus, if it is done, so there is no problem that there is increased bleeding or any like a rupture in the subsequent pregnancy will happen. So this is again new thing from in this guideline. Now they don't want any closure of peritoneum, neither visceral nor parietal peritoneum should be closed. Closure of abdominal wall, midline, if the midline incision is given, okay, then they want mass closure with a slowly absorbable continuous suture. Why they are doing mass closure? Because this decreases the chances of incisional hernia, and there are less chances of dehiscence. Okay, now coming to subcutaneous fat, this is, we already know it from the obesity guideline, from the previous guideline. So if the subcutaneous fat is more than 2 centimeter, then only subcut fat suturing should be done. Okay, and for the superficial wound drains, they don't want it. Okay, so there is no use for a recommendation for any wound drain in the cesarean birth. Apart from this closure of the skin, this is also new in the guideline. What they say, sutures rather than stapler. Sutures rather than staplers to close skin after a cesarean section appears to reduce the risk of superficial wound adhesions. So in previous one of the talk, they were saying like the staples are better, but this guideline says sutures are better or for than stapler. That because what they show, they have seen that the sutures are better because they will decrease the risk of wound adhesion. This is also new that is there in this guideline. Now, a time of antibiotic, we already know what antibiotic has to be given before the skin incision, and why we are giving it to decrease in endometritis, urinary tract infection, and wound infection. This number 8% is important for the part 2 people, because you will get, this is a very common question that comes, the incidence of infection after cesarean section, answer will come 8%. Thromboprophylaxis is also given for the that we know from our 37A and B number guideline. Now what they say about the care of baby, so thermal care should be arranged for the baby. If the baby has a low, because the baby will be born by the cesarean birth, they are more likely to have lower temperature. Okay, they want immediate skin to early skin to skin contact for the with the mother and baby. For the breastfeeding, even for the cesarean section, if the patient is wish to breastfeed, so they should be allowed and as soon as possible after the birth of baby. Okay, even after cesarean section, they want the breastfeeding to be started as soon as possible, or after the birth of the baby. Now about the post-operative monitoring, so what the guideline recommends, so if it is the cesarean section is done in general anesthesia, so there should be continuous one-to-one observation, one-to-one care to the woman till she is hemodynamically stable, she is able to communicate, and she has regained her airway control. Now, if that part is over, then monitoring should be done after this. The monitoring should be done after every 30 minutes or half hour for 2 hours, and after 2 hours it will be according to the hospital protocol if the patient is stable. Okay, so one time I have seen even the question from this slide also, though it is the almost same as from the previous guideline. So these are the recommendation for the observation for the post-op patient if cesarean section is done in the general anesthesia. Now what they say about spinal or epidural anesthesia, so they want one-to-one observation till she's hemodynamically stable. So and if the patient has dimorphine for cesarean birth, then in case of the spinal epidural anesthesia, or if any other comorbidity is there, for example, she has raised BMI, she has already diagnosed with with obstetric sleep apnea syndrome, so these patients are at a more risk of respiratory depression. So for these kind of patient, there should be continuous pulse oximeter monitoring. So pulse ox is continuous. Apart from this, hourly monitoring for respiratory rate, heart rate, blood pressure, temperature, pains, and sedation, and at least for 12 hours. Okay, a monitoring should be done at least for 12 hours. So now it is again same recap. So one-to-one observation till she's okay. If the patient is at risk, so many factors are there, then continuous pulse ox and hourly monitoring for all this, and it has to be done till 12 hours until they are stable. Okay, until the patient is stable. Now they also they very commonly they offer opioids for pain relief. So it can be done with a PCA. PCA is the patient controlled anesthesia. Like she can there is a device, and she can control how much she has to take. That is depend on the pain score. Okay, so if patient is on PCA and she is using opioid, so there should be hourly monitoring of respiratory rate, sedation, and pain score. And this monitoring should continue at least 2 hours after continuation of treatment. So this part, like, it was not there in previous guideline. Again, what they are offering after now after post-op, so what they can offer for pain management for cesarean birth, so dimorphine. So either they can give it intrathecally or they can give if the epidural catheter is already there. Okay, so these are the two ways. Apart from this, what they, this is new in the guideline, oral morphine sulfate can also be given. Oral morphine sulfate. And those women, they don't want to take oral medication because of the nausea, vomiting. So IV, IM or subcutaneous morphine can be given. So this part is new in this guideline, that this part was there, that dimorphine can be given intrathecally or it can be given epidural if the catheter is there as a, but this oral morphine sulfate can be given. So this is new in this guideline. Okay, apart from this, what they want, paracetamol if it is should be used, or any NaCid, because if the paracetamol or NaCid used, so that will reduce the requirement for this oral like this morphine use. Okay, so this oral thing is new in this guideline. Now, what they say, if the paracetamol and NaCid has been used and if the pain relief is still not there, so dihydrocodone can be given. But dihydrocodone should not be given to breastfeeding mother because it will cause neonatal depression. Okay, so you may get question from here. So what should not, if mother is breastfeeding and she is having pain not relieved by the paracetamol and NaCid, what drug should not be considered? So answer will be codeine. Okay, so this question can come. Now, another, what they say, if the patient is in the severe pain and pain relief is not there, that means some problem is there. So full assessment has to be done to find out if any hemorrhage is there, sepsis is there, or urinary retention is there. So if after assessment you find there is no problem, short course of tramadol or oxycodone can be given at lowest dose. Okay, and if the patient is breastfeeding and if like opioid analgesics such as morphine, dihydrocodone or oxycodone, it has been given, then it should not be given like more than 3 days without close supervision. Why? Because we are worried for a neonatal respiratory problem. So if these patient now they are on opioids, if they discharged home, then they should be given advice if the baby is showing any drowsiness, breathing problem, or constipation, or difficulty breathing, then they have to report. So this is the update that is new in this guideline that was not there. It is important to understand because you will get a scenario and you have to do answer. For example, they will say like baby, a patient has been discharged home and the baby is having breathing difficulty, constipation. So like what should have been given to this mother? So you will find out the answer will come as an opioid or it will come as a codeine. Okay, so this is new in this guideline. Now post-operative care, what they say, she can eat, a patient can eat and drink whatever they want when they are normal. Catheter should be removed after 12 hours of last top-up dose. Respiratory physiotherapy is not routine. Okay, this is same from the previous guideline. Now coming to length of stay, what they are saying, if the patient is recovering well, so they can be discharged after 24 hours. Okay, so this like this was not there in the previous guidelines, so I put it in a red mark. Okay, so they can, if they are doing well, they can be discharged after 24 hours, and then they will be called for follow-up. Now wound care, so what they say, like negative pressure wound therapy should be done for the woman if the BMI is more than 35. Why? Because to reduce risk of wound infection. This is there also in the obesity guideline. And for all other women, what they say that the dressing can be removed anytime it between 6 to 24 hours after cesarean section. Previously, it was like said after 24 hours. But in this new guideline, they are saying like dressing can be removed within 6 to 24 hours. So you can get question from this part also. So before removing this dressing, yeah, assessment should be done if any scar separation, increasing redness, pain, or any dehiscence is there. Patient should be asked to wear loose cloth, and cleaning is required daily. Okay. So the important part is that has been new in this guideline is the consideration for negative pressure wound therapy. Apart from this, dressing can be removed anytime between 6 to 24 hours. So this is new in this guideline. Now, what can happen after cesarean section? Urinary symptoms, UTI, stress incontinence, urinary tract injury, and urinary retention. What we are what we want here to remember this number, because you will get question from in the exam. So stress incontinence will be 4%. Even in my exam, I had this question. Okay, for this number, so you have to remember this percentage. So 4% stress incontinence will happen after cesarean section. Even this is a station in part 3 also, that the patient requesting for cesarean section because of stress incontinence. So you have to advise that yes, in the 4% patient, even after cesarean section, and stress incontinence can happen. Okay, so this number is important. Now the urinary tract injury is 1 per 1000. That also part 2 people had to remember this, because you will get question from here. Okay, so these both of the two numbers are important. Apart from this, patient can come with the irregular vaginal bleeding because of endometritis or because of retained products of conception. Okay, so apart from this, if the patient can come back with a respiratory problem or leg symptom, because cesarean section we already know that is a risk factor for embolism. Now, what they say about the resuming activities when they're discharging home, so they can drive or carry heavy weight or do exercise or sexual intercourse when they have fully recovered. Okay, so there is no timeline, nothing they have given it. Apart from this, with the cesarean section, there is no increase in the depression, no increase in a post-traumatic stress disorder or dyspnea, fecal incontinence, or difficulty breastfeeding. So you may get this one in the one stem of SBA. Apart from this, a GP should be informed for the follow-up investigation after discharge, such as FBC. So this also have added new in this guideline. Okay, yeah. So that's all that I had to say about the update from the NICE guidelines cesarean section. So I have changed color coded the things that highlighted the things that have changed in this new guideline. So before moving to another guideline, any one of you have got any question can ask me. Any question? Any question?
Hello.
Yes.
Hello. Good evening, Dr. Priyata. I'm Dr. Shivani speaking. I
Yeah,
had
yeah.
two queries. You mentioned that the wound dressing can be removed 6 to 24 hours. Is it only during fever, or it is like for regular removal of dressing?
Okay. No. Yeah, that is a good question you asked. Yeah, it is the removal standard dressing. So they have not said when the dressing has to be removed for any other patient, but yes, for the monitoring of fever, because they want to see the signs of infection, then the removal of dressing can be done anytime within 6 to 24 hours.
Okay. Okay, fine. Thank you so
What is
much.
what is the second question?
The second question I wanted to know, in the pre-op investigations, we mentioned FBC grouping and the RH status. Do we also do any coagulation parameters
No, no,
routinely?
no, 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 no. Please be very careful with that. I'll repeat that. This has been added new in this guideline. So what they say, you have to remember it very well. Okay, yeah, this was a slide. So uh, what they want for preoperative testing: full blood count, antibody screen, blood grouping with saving group and save. Okay, so there are three tests. So there are three tests: full blood count, antibody screening, and blood grouping with saving of serum. Okay, So these are the routine tests, and these tests are not done as a routine. Okay, now I think you have got your answer.
Yes, I got it. I think I skipped. I missed seeing that. Thank you so
Yeah,
much.
this is important. This is important. All of you should, like, for part 2 people, it is really important because it is a new. Okay, this part antibody screening has been new in this guideline. Okay, so this guideline you guys have already read already. Such some few updates. I wanted to cover this topic as a whole, so some updates only I'll be speaking. So now this guideline is bad guideline because it is full of numbers. Okay, numbers are too many numbers. So like, what is the success of VBAC? So if it is one cesarean section, so then it will be 72 to 75%. Okay, so the number has to be remembered from this guideline. If it is successful VBAC after one cesarean and one vaginal, so in your question, if you find one cesarean, one vaginal, success will be 85 to 90%. But if you find any of this factor in your question, like induced labor, like BMI more than 30, previous cesarean section for labor dystocia, so if like all these factor present, induced labor, BMI 30 and labor dystocia, in that particular situation, a successful VBAC is 40%. Okay, so this you have to remember because there had been question from all these part. Okay, now coming to the complication of VBAC and cesarean section, I have put the same table again. So uterine rupture, this number everyone has to know. After VBAC, uterine rupture is 1 in 200 or 0.2, 0.5%. In elective cesarean section, it is less than 0.02% or it is less than 2 per 10,000. Okay. Now, blood transfusion, it is easy to remember. You can remember it 2 by 1. So in VBAC, it is 2%. In cesarean section, it is 1%. Apart from this, maternal mortality also question comes. It is 4, like in VBAC, it is 4 per lakh. And in cesarean section, it is 13 per lakh. Okay, so this number you have to remember. Apart from this, like if VBAC is done, the chances for sphincter injury is 5%. But if the VBAC is done and the instruments are used, then the chances of sphincter injury increase to 39%. Okay, these are all numbers, I have put in the table, so like it becomes more presentable so that you guys can remember, but all numbers are important. Now, so that was the maternal outcomes. Now, this is the fetal outcome. So coming to respiratory morbidity with VBAC, it is 2 to 3%. And for ERCS, it is 4 to 6. So you can just remember respiration as a 2, 3, 4, 6. This way you can remember. Stillbirth VBAC, it is 10 per 10,000, but ERCS, it is not applicable. Hypoxic ischemic encephalopathy, it is 8 here and it is less than 1 per 10,000 here. So usually from this part I have not seen question, but yes, VBAC you have to remember this number. So for respiratory morbidity, VBAC, or elective cesarean section, you can just remember as 2, 3, 4, 6. So you will be able to remember this. And if you just think about VBAC, because the guideline is of VBAC, so what can happen to baby? So just remember by this like number if you wish. Like it is okay, death I have not written here. So if it is you consider to the like HIE, it is 8. If stillbirth is 10. I think this is not right here. Okay, so you have to remember this number. That is important. I wanted to make a mnemonic, I think, but some mistake had been there. So this number is important. So VBAC and ERCS 2346. Stillbirth is 10. 10 per 10,000. His hypoxic ischemic encephalopathy is 8 per 10,000. These numbers are important. These two numbers I have never seen a question. Now coming to suitability of VBAC, we already know that it can be done, it can be offered if the single pregnancy is there with cephalic presentation at 37 weeks or beyond. There has been single lower segment uterine cesarean section. Okay, so in this case we offer it, that we already know, that is nothing new about it. Now what are the contraindications? This part you have to remember and know. So if the previous uterine rupture is there, so that will be contraindication to VBAC. Now you have to remember this. This is already was also given within the lines of guideline. The chances of recurrent rupture is 5%. Okay, so this is given in the guideline. In between the lines, it was written. Classical cesarean section, it is a contraindication, and if any for any other reason cesarean section is already has been decided. Okay, so that will be the contraindication. So what you have to remember is the previous rupture and classical cesarean section. It is important for the part 2 people, because patient after cesarean section, she is looking for home birth. It is a very common station. It comes in every exam. So you have to find out whether she has got any contraindication or not. So therefore, it is important for part 3 also. Next, this is a new thing, and also important. If the patient gives you history of myomectomy, so what the guidelines say, if the cavity has been breached, or whether they are at increased risk of uterine rupture, there is uncertain evidence about it. Okay, so like all the time, we always, when we do when we see the patient with the myomectomy, we are always worried, okay, what has happened to cavity? Cavity was open or not? But what the guideline says, so we were always worried about the uterine rupture, but guidelines say there is uncertainty. Okay, uncertainty whether breach in the cavity isn't a point to as a risk factor for uterine rupture. Now what they also say, because of this uncertainty, if a patient with the uterine surgery is there, so management should be similar to the VBAC, and all risk will be same as a VBAC also. Okay, so you may get question from here, and part 3 already this station is there. So if the patient with a history of myomectomy, even with the cavity breached, the station has to be done as a VBAC station. Now this is also a controversial thing, but yeah, I have to speak. So risk of placenta previa in subsequent pregnancy. So with this one cesarean section, it is 1%. With the 2, it is 1.7%. And with the 3 cesarean section, it is 2.8%. So yeah, number has to be remembered. I really can't help it, because you get question from here also. Now coming to placenta accreta. So the number according to this guideline is this, and according to placenta previa guideline, it is this. Which one to follow is again a very difficult situation. But this cesarean guideline is this is given in the cesarean guideline. So if one cesarean section and placenta previa, so chances of accreta will be 11 to 14. If it is 2 cesarean section, then 20 to 40%. But after 5, the number is same. Here also they are saying here also they are saying 67, and here they are also saying 67. It again change in the guideline number, it is there, but we really can't help it. Whatever the update is there, so I have put it here. So these are the number from the VBAC guideline. This number, you question comes. Now what they say, if this is if the 2 or more cesarean section, if the patient in your scenario, if she has 2 cesarean section, lower segment cesarean section, she can be offered vaginal birth. Okay, but yeah, counseling has to be done by senior person, and all all the risk of uterine rupture, maternal morbidity, all the counseling has to be done. Okay, but again, so with so with the 1 cesarean section we were doing VBAC, with the 2 lower segment cesarean section also we are doing VBAC. But what they have already also like written, this was same thing is written in the guideline. So women seeking multiple, like 3 or more future pregnancy should be in future pregnancy they should be counseled for ERCS. So very clearly they are not saying this, that it is allowed, it cannot be done for more than 3. But in another line they say that if the 3 cesarean section, so they should be counseled for ERCS. So take home message, or according to the understanding from this guideline, it appears that up till 2 cesarean, up till 2 lower segment cesarean section, VBAC can be offered, and if it is 3 or more, patient should be counseled for elective cesarean. Okay, so this is the like sum up. Now again this is bad. Previously the question used to come, but recently I have not got to know the question like from this table. So after 2 cesarean section, what they wrote, success rate is 71%. Okay, you may get question from here, what is the success of VBAC after 2 lower segment cesarean section? Answer will come 71.1%. Okay, uterine rupture after 2 cesarean section is 1.36%, and hysterectomy is like 56 in 10,000. If you compare it to 1 cesarean section, so it is 19 per 10,000. Okay, so this is, again there are so many numbers, but at least one number you can remember. Number like risk of success rate after of VBAC after 2 cesarean section is 71.1%. Minimum at least one you can remember. Now like what are the factors that increase the risk of uterine rupture? So you may get question from there. So what are the factors? Like if the shorter interval, inter-pregnancy interval is there, less than 12 months from last delivery. If it is post-dated pregnancy, maternal age is more than 40%, increased BMI or obesity, low Bishop score, macrosomia, and USG decrease lower segment thickness. Okay, so what they say as a cutoff, like if it is 2.1 to 4 mm, then like it is a strong negative predictive value. That means the chances of scar adhesions will be very low. But if it comes in between 0.6 to 2 mm, then it has a strong positive predictive value. That means the chances of rupture are high. Even when we are doing cesarean section, we are taking any patient for VBAC, we always ask sonologists to tell about scar thickness. So this scar thickness we are looking at. So if we see in their USG scan report, the scar thickness is less than 2. So we immediately say, okay, you need to go for cesarean section. And if it is more than 2, we are not too much worried. Okay, so this way you can remember this number. Now whenever a patient is going for VBAC, it is always the counseling has to be done. And if she is going for elective cesarean section, so there should be a plan if labor starts in between, and there should be all checklists about the antenatal counseling should be done. Like one important number that is important from here is this 10%. So if the patient says, okay, I'll go for elective cesarean section, then how much number of the women they will go into labor? So it is 10%. Okay, this you must be knowing this number. So with 10% of the women with a scheduled elective cesarean section, they will go into labor before 39 days. So this number you will get question from here. Now, what are the risks? Though I have already spoken in the table, but what is the greatest adverse outcome of the trial of VBAC? So greatest adverse outcome is the emergency cesarean section. And what are the chances of emergency cesarean section? It is 25%. This number is important for part 3 people, because they ask this question, what are the chances that I can go require an emergency cesarean section? You will say 1 in 4. Okay, So because on the other side, we already know the success is 75%. So that means 25% failure. 25% failure means cesarean, emergency cesarean section. Okay. So this is the greatest adverse outcome. This is the terminology that used in the guideline. Now, how many percent chances of uterine rupture? That everybody knows this number. It is 1 in 200. Apart from this, this line is also important to know. So if the patient is going in labor after VBAC, so risk to baby, perinatal death or in birth related perinatal death, it will be like comparable to the nulliparous in the labor. From this line, usually the question had come. So this you have to know. Apart from this, if the lactive cesarean section is done, we already know there is increased risk of placenta previa occurred in the future pregnancies. Okay, so this part you have to know. And usually if the cesarean section is planned, it is planned after 39 weeks because to decrease the respiratory neonatal problems. Okay, so this is all this, though I have discussed, but again, if any previous vaginal birth, particularly successful VBAC is the best predictor. So if you get in question what is the best predictor for successful VBAC, so your answer will be successful VBAC. Okay, so please because most of the people, what they will do, they will put previous vaginal birth as a successful factor. But see your list completely. If you have a successful VBAC vaginal birth, so your answer will become successful VBAC. Okay, and this number we already know. Now, what are the factor associated with increased success? If the increased maternal height, if the age is less than 40, maternal age less than 40, gestational age less than 40, and baby is less than 4 gram, or like weight lower than the index pregnancy when the cesarean was done. So all fours are there, okay, all four, and BMI less than 30. So this way it will be important, easy to remember that the success will increase. Greater maternal height, we already know that if the height is more, there will be good size pelvis. And so apart from this, just mother age less than 40 years, baby age less than 40 weeks, mother should be slim mother, like less than 30 BMI, and baby weight should be less than 4 kg. So these are the factors that are associated with success of VBAC. You will get question from this line, and this way it becomes easy to remember. Apart from this, I have seen question from there also. So like they have given individual also. Like if previous cesarean section has been done for malpresentation, 84% chances of success of VBAC. If it was done last pregnancy for fetal distress, so it is 73%. And if it is for labor dystocia, it is 64%. So sometime even I have seen question from this part also. So therefore I have put this here, okay. Now, if we do VBAC, so we have to do continuous intrapartum monitoring, okay? And usually it is done in the setup where emergency section can be done and neonatal resuscitation can be done. This question you may be, you will get this also as a question. If epidural, like in VBAC, if the patient wants for pain relief, epidural analgesia is not contraindicated. But if there is an increased demand of it, so you have to think, okay, there could be possibility of rupture. And continuous fetal monitoring has to be done, that we already know. Apart from this, like these are the component for intrapartum care for VBAC: supportive care, IV access with FBC, blood group and save, continuous fetal monitoring, regular monitoring of mother symptoms and sign. Why we are worried? We are worried only for the scar dehiscence. There should be regular monitoring, vaginal monitoring. It should be 4 hourly, okay? It should be 4 hourly, no less than 4 hourly it should be done. Now you will what are the clinical feature we will see in the patient if that is associated with the scar rupture. If the abnormal CTG, it is usually the first sign, okay? And it is usually present in 66 to 76% of the patient. You will get question from this number also. This number I have put in the question, okay? If any severe abdominal pain, usually when the contraction goes off, patient is a bit relaxed. But if in between contraction also she is having pain, yes, there could be possibility of rupture. Acute onset scar tenderness, abnormal vaginal bleeding, hematuria, cessation of previously effective efficient uterine cavity activity. All of a sudden you will say that patient has become or uterus is not contracting, and all the contractions are gone. If you see CTG, that you have to think for scar rupture. If maternal tachycardia, hypotension, shock, that everybody knows. Loss of station, all of a sudden, like if the labor was progressing well, so contractions are gone, and there is a bleeding, and whatever the part station, if it is what was there, so it will be it will lose, okay, because now there is no contractions are coming. So apart from this, we are not able to pit fetal heart. So these are the few signs and symptoms, clinical feature associated with uterine scar rupture. So usually you get question from here also. Usually they will put a scenario that there is increasing abdominal pain and patient is asking for more pain relief. Apart from this, they also put in the question that there is a cessation of efficient uterine activity. So because rest, everything, everyone knows. These two lines usually, you will not think of it, but a question comes from this line also, these two lines only, okay? So if you find this two lines, like she's asking for more pain and there is cessation of activity, you should think of scar rupture as an answer. This is also important. Like usually they want that VBAC patient, like if the patient is want to go for vaginal birth, so they should be allowed for spontaneous, okay? Because what they have seen, like if the induction is done, so with the induction 2 to 3 times there is an increased risk of rupture, and 1.5 times there is an increased risk of cesarean section. So these two numbers are important. Apart from this, like if the induction of labor has to be done, so what they say, it is better to be done with the mechanical method such as amniotomy, ARM, or Foley's catheter, rather than using prostaglandin, because we already know with sometime with the prostaglandin there is so much contraction that will increase chances of rupture, okay? So this part you have to understand. This part is very important because many times the question comes and answer is Foley's catheter. Even people have sent me so many the question and the answer was Foley's catheter and they were not convinced, okay? So this is from the guideline only. Now, if the elective cesarean section, we know it has to be done after 39 weeks. Antibiotic prophylaxis has to be given. In the guideline, once they mentioned, though antibiotic prophylaxis will be according to the hospital protocol, but in the guideline, once they wrote that ciprofloxacin and metronidazole. So this will be sort of an antibiotic prophylaxis, what they put in one part in the guideline. Thromboprophylaxis assessment has to be done. That is from the VTE guidelines. Okay, apart from this, like this is what they say, if the pregnancy, there is an uncertainty whether the VBAC should be planned or not. So what are the factors for uncertainty? If it is a post-dated pregnancy, if it is a twin pregnancy, if baby is macrosomic baby, if there had been stillbirth, or if their maternal age is more, whether the VBAC should be offered to this woman or not. So actually there is an uncertainty about the safety and efficacy. Okay, apart from this, if patient is preterm and VBAC is planned, then the chances of success will be same as for the planned VBAC. But very good thing is that chances of scar rupture is less. Okay, chances of scar rupture is less. So yeah, so that's all that I had to say for VBAC guideline. So any one of you have got any question can ask me, otherwise I'll be moving to questions. Any question? Okay, okay, now I'll go to questions. Okay, so what percentage of women will have cesarean section in UK?
B.
Yes. Now the
B.
previous no. So who said B? I just told you in the beginning, first page I told you, previously it was 25%, but this guideline, it has become 25 to 30%. So you have to remember this new number. You will get question from there, okay? Please be
Okay.
very careful. Okay, which of the following useful in predicting cesarean section for CPD in the labor? Pelvimetry, for decision making for mode of birth, maternal shoe size, maternal height, estimation of fetal size, ultrasound clinical examination, or none of these?
Maternal height.
No. CPD.
Oh, sorry.
Yeah, CPD. What we just read, it is about success. What are the factors that will increase the success of VBAC? Okay. And this question is saying prediction of CPD. So what will be the answer? It is given in the guideline. It is on the guideline only. It was there in last. No. Answer is this. None of this. So no fact, whether pelvimetry, maternal shoe size, maternal height, or estimation of fetal size. We can't predict CPD. Okay. Planned cesarean section to be offered with which of the following BMI? 30, 35, 40, 50, not related with BMI. Yeah. Yes, it is not related with BMI. No relation with BMI, okay? So like 28-year-old woman in first pregnancy, she saw a vaginal birth video. She got scared because it comes as a flashback of a previous incident. She wants cesarean section now, requesting. So what you will do? You will accept her request. You will explain risk of cesarean section.
5. 5.
Yes. This
Mental
woman
health.
refer to perinatal mental health expertise. Okay, we just did that. Now, which of the following has role in reducing cesarean section? Walking in labor, non-supine position, immersion in water, epidural analgesia, or partogram with 4-hour action line?
Partogram with 4-hour action.
Partogram. E.
Yes, partogram with 4-hour action line. Now, like 38 years old woman, she has to go cesarean section tomorrow. What are the pre-op tests to be done? Now, Shivani can answer it.
E. Sorry.
Yes, answer is E. Full blood count, antibody screening, blood grouping with saving of serum. Okay, so this is the answer. This is update from the new guideline. Now, what percentage of the patient will go into the labor when planned for elective cesarean?
10%.
Yeah, that we already know.
10%.
Fine. Yes. Which of the following is the best predictor for vaginal birth? Previous vaginal birth, VBAC.
Two.
Previous VBAC.
Okay, just now I explained it. Yes, it is previous VBAC. Now, which one of the following is not the component for intrapartum care in VBAC? Supportive one-to-one care, IV access, continuous fetal monitoring, regular monitoring of maternal symptoms and sign, regularly too early assessment for cervicometric progress in labor.
5.
5.
5th one.
Yes.
Regular.
Because it is 4-hourly. Okay, it is 4-hourly. 32 years old woman planned for cesarean section. Midwife suspects scar rupture. Which one of the following is the most consistent indicative of scar rupture? Abnormal CTG, severe abdominal pain, persisting in between uterine contractions, acute onset scar tenderness, abnormal vaginal bleeding, and hematuria. So, which is the most consistent sign?
Abnormal
Abnormal
vaginal
CPG.
bleeding.
Yes.
Abnormal CPG.
Yes, abnormal CTG, and it is present in between 66 to 76%. Okay, so this number is also important. Now, a patient has a history of vaginal birth and with a cesarean section, and she wants to attempt vaginal birth. So, what will be the success?
85 to 90%.
E.
Yes. Yeah, now
D.
you guys already know this. Okay, so now it is a 29-year-old, 20-year-old with a 36 weeks pregnant. She was in antenatal clinic. She had a previous cesarean section, but right now she has a cephalic presentation, normally grown baby. There is no medical and obstetric problem. She is deciding for VBAC, and she has to decide, okay, whether it is VBAC or whether it is elective cesarean section. So which one of the following is correct in counseling? When she will receive? What is right?
Five.
Yes,
Fifth one.
5. Yes, because you already know this number. Risk of rupture is 0.5% or 1 in 200.
1 200.
Yes. So it is similar kind of question. So she has opted as elective section for mode of delivery, while counseling for elective cesarean section, which will be valid statement. All women should receive antibiotic prophylaxis. All
No.
women should.
1.
Yeah, 1 is the answer. Yes, because all of the women will receive antibiotic prophylaxis. Okay, and second cannot be right, because all women, they don't receive thromboprophylaxis. There will be DVT risk assessment. Okay, elective cesarean section should be done at 39 weeks. General anesthesia is not safe. Regional anesthesia is safe. And on an average, patient will need hardly for 24 hours to recover in the hospital following CS. Okay. Again, this is the same question. So what are the risk of rupture? You will quote if this woman will go for VBAC.
More than 1 is to 200.
So it is 0.5. Okay, so this 27, 27-year-old woman, she last cesarean section was 8 centimeter dilatation for abnormal fetal heart rate. Okay, so problem with the fetal heart was there. Baby is okay. So what will be the success now of VBAC?
71 to 75%.
B.
Yes. So actually, if you see from the guideline, it is 73%. Okay, it is
74.
73%. Yeah, it is no, it is 73%. Okay,
Okay.
it is. So for fetal
74,
malpresentation,
73,
84. For fetal distress, it is 73. Liver dystocia, it is 64. So here it should be 73. So B will be the answer. Now you are performing cesarean section. A 20-year-old woman with a she had previous myomectomy. Okay. Now you are doing cesarean section and she consented. She want to have more child. After delivery, syntocinon was given. You wanted to deliver placenta, but it is firmly adherent. Uterus is well contracted. There is no bleeding. So what you should do? You should give her terbutaline, close uterus and hysterectomy, manual removal of placenta and uterine artery embolization.
Close uterus.
Yes, close uterus, because the patient is not bleeding. There is no problem. So there will be aseptic autolysis for placenta. Okay. Now, okay, I have already given the answer. So if you, you are doing, you're supervising your junior who is doing cesarean section for second stage, there had been like problem with the impaction of the head. So you are unable to disimpact the head from the maternal pelvis. What you should do? So this is the answer, and this is the talk from there this question has come. So now you should also, it is important for part 2 and 3 people both. So if the fetal head is impacted, so these are the things that can be done. Okay, these are the things that you can stand up on the stool, or you can tilt the table down, wait for the contraction, or help someone to apply pressure on his shoulder. extend the incision to J or T shape. Okay. Now, 32-year-old woman in the antenatal clinic with a 40 weeks of pregnancy. In her first pregnancy, she has elective cesarean at 39 weeks for breech. Now she requested VBAC. So she is concerned about the length of her pregnancy and request induction of labor immediately. So what will be the advice for her? So she wants a
spontaneous labor.
Yes. So this is the answer. With this I told also. So if the patient has VBAC, usually we want spontaneous labor to start, because if it is a spontaneous labor, better Bishop score will be there. If the better Bishop score is there, chances of success for VBAC will be more. So if you see that table, so like what they say at 41 weeks, they have opted for planned VBAC. So, and they have not gone into spontaneous labor. Indirectly, they want that patient should wait for spontaneous labor. Like 35-year-old woman with 135 kg weight, BMI 52, 3 previous cesarean, admitted at 39 weeks of pregnancy. She had an intraperitoneal hemorrhage for 2 liters. What will be the post-op instruction? Indwelling catheter for 72 hours, intraperitoneal drain, daily wound review by midwives for 12 days, to administer 5,000 unit deltaparin per day, to use pneumatic compression boots until she is mobile or while she is asleep.
Suction drain.
Why suction?
5.
Yes, 5. So if there had been increased hemorrhage, now you see here this patient is they want they're speaking about DVT. Okay, they want to give her thromboprophylaxis. So they are checking your knowledge what you will do if intraoperative hemorrhage is there. So like if any patient has bleeding or patient is at a risk of bleeding, then consideration for mechanical method should be done. This is from the 37 guideline. So if any patient is at a risk of hemorrhage, intra-abdominal bleeding, hematoma, post-op hemorrhage, she should be managed with the anti-embolic stocking, foot impulse device, intermittent pneumatic compression devices. Okay, so this would be the answer here. UFH can be considered. Okay, can be considered. Now 39-year-old with the elective cesarean section for breech presentation. She had an uncomplicated procedure and she is mobile on the same day. Okay, so what will be the most operative venous advice about the venous thromboembolism prophylaxis you will give?
Ma'am, 3.
Yes, very good. Now you will see this patient is age is 39. Age 39 is risk number 1. Score is 1. Elective section is score is 2.
1.
1. So total score is 2. And if the score is 2 or more than 2, consider thromboprophylaxis for 10 days. So now if you see whole scenario and if you don't correlate with the guideline, you will say answer is 1. Mobilization, avoiding of dehydration. But if you do scoring and if you follow the guideline, then your answer will become right. Okay. So 3 is the answer. Very good. Now 38-year-old for the elective cesarean section, her BMI is 32. Okay, her mother and sister have DVT in past. In post-operatively she have swollen leg, shortness of breath. Examination, her leg is blue, so leg is difficult to move. So what will be the next appropriate step?
Arrange a leg Doppler scan.
Commence therapeutic fixing.
Commence
4.
Yes,
4.
so 4, because we already know from the guideline that on the suspicion They will start
Oh,
heparin, then they will do the like all testing. Okay, so it will be commence therapeutic dose.
ma'am, it is because of the symptomatology they are giving, right?
Yes,
And
yes,
then
yes. Now, 29-year-old woman for antenatal clinic for booking. She has complicated cesarean elective section for breech in first pregnancy. She has come here to discuss about vaginal birth. So, what should be the counseling, and what should should be made aware of? What should be the answer? So, her chances of having successful vaginal birth is, we already know, 75. Risk of emergency cesarean section is same. No,
no.
risk of emergency cesarean is same as if in labor for first time. No risk of emergency cesarean section this time will be high. Her baby will have more initial breathing problem with vaginal birth. No, breathing problem happen with cesarean section. Question for like 4, risk of harm to baby is same as she was for first time in labor. This is right because the rupture is 0.5%. Okay, so this will be the answer. Even I showed same in the when we were doing the class, then also I showed. So absolute risk perinatal death risk associated with VBAC is extremely low, and it is comparable to the risk of nullipera in labor. Okay, so at that time also I highlighted this point. Okay, now a few things about this talk. Now this is again this is a all the questions will come from this talk. Okay, so in according to this talk, latest National Health Service maternity statistics for England suggest what is the current rate of cesarean section?
25, 30.
25 to 30%.
2,
It is
30.
30.
30, yeah. So now you can see that the guideline says 25 to 30 and talk says 30. So there is an increase in cesarean section. Okay, now cesarean niche is commonly defined on the ultrasound as hypoechoic area in the lower anterior lower uterine segment, represents a defect in the myometrium. So what could be, it can appear in different shape and sizes. What is the most common? Triangular, semicircular, triangular or semicircular, vertical and horizontal.
Semicircular.
C.
Yes, C is the answer. It could be triangular or semicircular. So greatest risk factor for cesarean niche: single layer closure, double layer closure, continuous closure, ischemia due to interlocking of suturing, does not depend on this technique of cesarean section. Yes, answer is C. Ischemia due to interlocking of suture. This is the greatest risk factor. Now you can see it from here. So by locking suture, it is the greatest risk factor for cesarean niche development. Now, most common symptom with in the woman with cesarean niche. So it will be it will be post-menstrual spotting. It will be prolonged menstruation. It will be post-menstrual spotting and prolonged menstruation, infertility and chronic pelvic pain. So what should be the answer?
A.
Pelvic pain.
A.
No.
Chronic pelvic pain.
No. It is very clear answer here. Sometimes the longest is the answer. Okay. Post-menstrual
C.
spotting, post-menstrual spotting and prolonged menstruation is the answer. So, what is the best diagnostic imaging modality for cesarean niche? It is gel installation, sonohysterography, TVS, TS, or X-ray.
TVS.
Gel installation.
2. TVS.
Yes.
No, it is GIS.
GI is
It is
longest.
GIS. Yeah, I just made some questions. Okay, so you will remember this. Now, cesarean niche is defined as an indentation at the site of cesarean section. What is the depth of 1.5 mm, 2 mm, 2.5 mm, 3 mm, or 3.5 mm?
B.
The depth width
Very good.
A. It will be.
So it is B. So this is the knee. This is the knee's definition: scar defect of at least 2 mm in depth. Okay. So this they say this what the talk said. Now, so what is so you see? So this is a cesarean niche. Okay. So now you see this is the like if it is a USG picture. So this is the uterus. Okay. This is the cavity, and here the previous cesarean section was done, and this is the gap. Now when this so what we measure in the cesarean niche, we measure this residual RMT. RMT is residual myometrial thickness, and from where it is measured? It is measured from apex of niche to serosa. So this is the apex, this is the niche, this is the apex of the niche, and this is the uterine serosa. So measurement of this is the RMT, it is done. And why I'm speaking about this now you can see what is the management for cesarean niche. So what they say, IUS, intrauterine device, endometrial ablation with a roller ball ablation to the niche cavity. It is a less invasive option in the women who want fertility. So if your patient comes with like fertility thing, so I don't know how IUS will be the answer, but yeah, endometrial ablation could be the answer. Okay, so IUS or endometrial ablation, what they say, if this is less invasive method with, okay, it is without fertility requirement. She doesn't want fertility. So if no fertility, ask for IUS, ask for endometrial ablation with a roller ball. Now, second scenario, your patient is looking for fertility. So what you will do and how you will decide what should be the treatment. So if the RMT, if it is like less than 3 mm, if it is less than 3 sorry, if it is more than 3 mm, that means uterine wall thickness is more, so it can be managed hysteroscopically, resection of niche. Okay, so these are the hysteroscopic picture. You can see that in the first picture there is a niche, usually it appears as adhesion. In the second picture they have resected it with a resectoscope. Okay, now if your patient, if the ultrasound shows that it is a large niche with the RMT is very small, thin RMT is there, only less than 3 mm. In that situation, if you do it with the hysteroscope, perforation is going to happen. So what they want, if it is like less than 3 mm, consideration for laparoscope, combined approach, laparoscopy, hysteroscopy. So it has to be done under laparoscopic guidance. And what is usually done in the laparoscopy, if they do, they will like excise the whole scar and they will stitch it like we do in a cesarean section. Okay, this is a number I found important. Remarkable improvement in abnormal uterine bleeding and pain after hysteroscopy resection. It is 74%, and with the laparoscopy it was okay. I missed it. So with the laparoscopy, what they say, it was almost 100%. They are happy with their symptoms. Okay, yeah, so that's all. Okay, so that's all I had to say. Any one of you have got any question can ask me. Any question, anyone? Anyone, any question? Okay, so thanks for coming to class. All the best and bye.